Hello, it is now 2 p.m. Eastern Time. You have joined the Justice and Mental Health Collaboration Program field-wide webinar on strategies for planning and implementing a comprehensive crisis system. To allow for additional sign-ins past the hour, we will be starting this webinar in a few minutes. Good afternoon. Thank you for joining today's Justice and Mental Health Collaboration Program field-wide webinar on strategies for planning and implementing a comprehensive crisis system. My name is Ethan Kelly, and I'm a senior policy analyst at the Council of State Governments Justice Center. I will be moderating today's webinar, which is hosted by the U.S. Department of Justice, Bureau of Justice Assistance, and the Council of State Governments Justice Center. To give you an overview of today's webinar, first, we will do introductions of our panelists and organizations. You will hear a presentation about building a comprehensive crisis system from planning to implementation. And we'll hear from a Justice and Mental Health Collaboration Program grantee site to talk about the efforts in their county around crisis response and how they are continuing to improve. And towards the end of the webinar, we'll have time for questions and answers. A few housekeeping items. Anytime during the webinar, you can ask a question by clicking the Q&A button at the bottom of the screen and entering your question. This includes both technical and content-related questions. We will try to reply to technical questions in the chat as we go. For the content-related questions, we will keep a running list and address them at the end of the webinar. We will do our best to get through as many questions as possible. If you encounter technical or audio problems during this webinar, please click on the link that we shared within the chat. Please understand that there are some technical issues that we may not be able to resolve. We are recording the webinar, and we will post it along with the PowerPoint slides on our website within 1 to 2 weeks. And now for our introductions. For today's speakers, we have Sherry Blythe, the Director of Crisis Services with Specialty Substance Use Treatment and Justice Initiatives. Marissa Malik, the Practice Administrator of Crisis Services. We have Dr. Kenneth Minkoff, the Senior System Consultant of Zaya Partners. Kent Halsapple, the Director for Sangamon County Court Services, Sangamon County, Illinois. and Diana Kanabe, the President of Memorial Behavioral Health for Sangamon County, Illinois. Thank you all for joining today's webinar. I'm going to give some background on the Council of State Governments Justice Center. The Justice Center is a national nonprofit, nonpartisan organization that combines the power of a membership association representing state officials in all three branches of government with the expertise of a policy and research team focused on assisting others to attain measurable results. Our staff develops research-driven strategies to increase public safety and strengthen communities. The Justice and Mental Health Collaboration Program, or JMHC as we call it, was established in 2005 and is funding the training today for the field at large. Some of the attendees may currently have a JMHCP award or may have received one previously. We do this work with the funding through the Bureau of Justice Assistance and the Office of Justice Programs. BJA's mission is to provide leadership and services in grant administration and criminal justice policy development to support state, local, and tribal justice strategies to achieve safer communities. BJA works with communities, governments, and nonprofit organizations to reduce crime, recidivism, and unnecessary confinement and promote a safe and fair criminal justice system. I'm now going to turn it over to the National Council to talk about their organization. Dominique.
Thank you, Ethan. I appreciate it. Welcome, everyone. So despite the overwhelming need, nearly 30 million people across the U.S. don't have access to affordable, comprehensive mental health and substance use treatment. That's where the National Council for Mental Wellbeing comes in. We have been serving on the front lines of mental health and substance use care since 1969, fighting to ensure all Americans receive the high-quality treatment they deserve. That means ensuring equitable access to services, building capacity for care delivery, investing in the workforce, and promoting mental well-being as a core component of health and healthcare. We are guided by our vision that mental well-being, including recovery from substance use, is a reality for everyone, everywhere. It's who we are. It's what we do. We have 3,500 mental health and substance use organizations serving more than 10 million children, adults, and families across the country. I will now turn it over to Dr. Ken Minkoff, who will discuss the planning of an ideal crisis system. Thank you.
Thank you, Dominique. And hi, I'm Ken Minkoff. I'm with Zia Partners in Tucson. I'm also the co-chair of the Group for the Advancement of Psychiatry Committee on Community Psychiatry that developed the roadmap to the ideal crisis system. And I'm going to be working with colleagues from Austin Travis Integral Care, Sherry and Marissa, to talk to you about how the roadmap guides the design and planning and implementation of the ideal crisis system and the work that they are doing, not only locally, but as partners in a national learning community using the roadmap to help their crisis systems evolve. Next slide, please. So we're going to be focusing on section 1 of the roadmap today. What I'm going to be doing is explaining to you guys what the roadmap to the ideal crisis system is as a tool for you to use in guiding your progress in crisis system development. There's a lot in it. And so we're going to be focusing primarily on the content of section 1. Which has to do with community collaboration, building partnerships at all levels for funding and accountability, developing and designing a vision for where you want to go, creating mechanisms for accountability and performance management, bringing in multiple funding partners and service partners, and then developing a strategic improvement and implementation plan. So let me tell you a little bit about the roadmap and its background. Next slide. The roadmap to the ideal crisis system was, as I noted, a report by the Community on Psychiatry and Community for an organization called Group for the Advancement of Psychiatry, of which I am a co-chair of that committee. And it was published by the National Council for Behavioral Health at the time, now Mental Wellbeing, in the spring of 2021. And the reason that we developed this report is because we knew then, and it's even more apparent now, that 988, the 988 call line, the national call line for behavioral health crisis services, was in the process of being implemented and then has now had a soft launch just a few weeks ago. But we know that just creating a number for people to call doesn't create the crisis system that people need. And that we need to be moving from a vision from the current reality where behavioral health crisis services are often just an add-on. And in many places, law enforcement becomes the default first responder, to daring to envision a crisis system that is responsive to the needs of our population at the same level that we think of other public health and public safety net responses. So our committee took on the task of not only defining that vision, but thinking about how to provide concrete, step-by-step, measurable information for communities like yours who are trying to figure out how to design the system that the people in their communities, your communities, actually need and should have. So we call this the roadmap to the ideal crisis system, essential elements, measurable standards for each one, and best practices. And it's a 200-page document that has lots of detail for you to use. And so obviously we're not going to cover every one of those details in this webinar. So, but I want to introduce you to the basic structure and then dig into the ways in which communities can use it for planning and implementation. And then you get to see some real communities actually using it for that purpose. Next slide, please. So the first aspect of this report is the vision that I described. Daring to envision that we should have an ideal crisis system in behavioral health is already a radical statement. And we are moving now collectively as a nation from beginning to think that any behavioral health crisis program is wonderful because we expect so little, to creating a vision of what we should have and then thinking about how we're going to get there. So a crisis system is not a single program. It's not a single thing. It's not a 988 line. It's not one mobile crisis team any more than your emergency medical system is one emergency room or an ambulance. The crisis system for behavioral health is an organized set of structures, processes, and services that are in place to meet all types of urgent and emergent behavioral health crisis needs in your community effectively and efficiently. And the vision is that every individual and family in every community will have access to a continuum of best practice services that are welcoming, person-centered, recovery-oriented, and continuing, not just one and done. We have to regard this as an essential community service, just like police, fire, and emergency medical services, and that every community should expect a highly effective behavioral health crisis response as it expects those other systems to work seamlessly to meet community need. Next slide. In the context of the design, and this is important when you're starting to plan because it may seem like you want to skip this part, but begin your community conversation by articulating not only the vision, but the principles and values that you're going to use to get there. And this is a significant thing of moving away from the idea that behavioral health is an offshoot of criminal justice. Behavioral health crisis response stands on its own as a thing that people need who are in desperate situation. So we have whoever is participating in this is committing to a shared set of values about welcoming, engagement, customer-oriented, hopeful, safe, et cetera, that our collective system and all our partners are collectively accountable for the people and populations of our community, whoever they are, wherever they show up. We know that people in behavioral health crisis are going to show up with co-occurring and complex needs. It's not just narrowly defined so that people are excluded. It's open for the idea that people show up with all these things going on. So we want to plan how to respond appropriately. We have limited resources. We always do. So we want to do this in a way that maximizes the reach of those resources, but to meet the needs of our population. And we want to have access for people who show up voluntarily and encourage that, but at the same time, make sure that those people who need to access services only through involuntary means can have that happen when absolutely necessary. And we're organizing what we do, not like we do this once and we're done, but we're constantly using performance data to improve our services to create better responses over time, just as we do with other kinds of systems, including emergency medical systems. Next slide. So when you use this report, and there are links to the report in the slide set that you will get, and our committee has also set up a direct website that we are populating with additional information called crisisroadmap.com, which is kind of an evolving project of our committee now that we've had to put the roadmap on. So you can check out crisisroadmap.com as well as the link in the slides. But the report, starts with the values and the vision, and then it divides the process of development into 3 major sections. And as I said, we're going to focus on the first one. The 3 sections are a section on designing a mechanism of accountability for planning, implementation, and performance that includes, but is not limited to, bringing together all the resources that are needed to fund the system at capacity for everyone in need. The second section, which is where most places start, so we're purposefully reminding people to start thinking about the first section, is the second section is your array of services and capacities. So it's not just a program, it's not even just a list of programs. It's a way in which you develop a service array that meets people at multiple places, multiple needs through a continuum of service, which sounds kind of radical, except that that's how our medical system operates. And we need to build this into the behavioral health system as a safety net component for the ongoing non-crisis services that have to be interlinked. And the third section describes what happens to people when they show up at the service, because we need to have the expectation that people are using the best available clinical practice to do assessments and interventions and determination of people's needs in crisis so that they can get the help they need over time to restore themselves to baseline equilibrium and then continue to make progress. So all 3 components are important. Next slide. And we have these cool little diagrams. We have a couple of them in the slide set. And this shows how these things all intersect. There's a foundation of system oversight and governance that's planning and implementation responsibility. There's an array of services and capacities, best practices. There are the direct wraparound people in the community, including first responders and families. Everybody's lined up to support the person in crisis. Next. So in the first section, this is what we're going to concentrate on. I'm going to move through all 3 sections quickly so you can see them together. And then we're going to go back to this slide and dig into this. But section 1, accountability and finance. An ideal behavioral health integrated crisis system must have a mechanism to finance and implement a comprehensive continuum of crisis services, and a corresponding mechanism, they're often the same, to ensure oversight, accountability, and quality of the performance. So one of the things that you're going to see as you listen to the examples today is the way that the county entities in each instance are occupying the role of the accountable entity and using that framework to create the collaborative partnership within which all of these things are figured out. I'm going to go back to that in some detail, and you see all the elements that are part of this thinking. Next slide. Okay, next slide. I'll talk more about this. Next slide. Okay, so the second section, as I said, involves the crisis continuum basic array of services and capacities. Now, one thing I want everyone to notice in the pictorial stuff, which is a little hard to see in the slide, is that there are elements of the continuum. There's a list of things that, I'll quickly mention. But even before we get to that, there are capacities that need to be in place in that continuum. And it has to do with having the overall design of how people flow through it, meeting the ongoing needs that are matched to the volume of the community. But the preparation to be responsive to adults, to children, to older adults, to people in behavioral health crisis who may have intellectual and developmental disabilities, who may be immigrants, who may not speak English, and so forth. And then making sure that we have the workforce, the staffing capacity, both frontline people, peer support, as well as clinical leadership throughout the continuum that holds it together and helps it to do a good job, just as we expect when we get emergency medical care. And then there are elements of the continuum, as you can see, including the call center, the 988 center, some sort of crisis center, mobile crisis teams, behavioral health urgent care walk-in centers, continuing intensive community-based crisis intervention, emergency rooms, inpatient units, transportation, all of that stuff that has to be developed with attention to all the population needs at the right level of capacity. And they have to interlink. They have to be able to work together so they function as a seamless system. Let's move ahead to the next slide. And then the next slide, and then the next slide. So we're not going into all those details now. You can ask questions about it. In section 3, what do we mean when we're talking about basic clinical practice? Well, there are actual practice guidelines that have been written about, but it's striking that there's an extensive literature and language about the standards of care for emergency medicine. That people actually implement in real world systems, but not so much for those same basic clinical practices for behavioral health. There are basic guidelines for 988 centers and suicide response lines, but extending those throughout the system so there's really an implemented standard and people get what they're supposed to get when they show up, it isn't there. So we outlined core competencies for engagement, assessment, and intervention, how to do formalized screening and intervention to promote safety in relationship to suicide and aggression, practice guidelines for intervention and treatment with various kinds of populations, different ages, different types of comorbidities, population-specific clinical best practices for ongoing intervention, and then how the whole system engages in best practices for collaboration, coordination, continuity of care, care management, critical time intervention, and information sharing all throughout the system. So each of the essential elements that's listed is associated with measurable indicators of progress that as a system, you can use to ask yourselves, where are we going? How are we going to get there over time? And how do we incorporate measurable indicators into our contracting and design process so that we're holding on to our vision and then moving slowly in the direction of that vision? So now can we go back to slide 16? Here we go. So, let me move, actually, let's move to the next slide. Okay. So I'm going to start right here with this idea of an accountable entity. So think about your community. Every community is a little bit different, and the way that service planning for behavioral health gets organized is different from state to state. So it's hard to exactly think, that I can say one size fits all for your planning process. In the examples that we're using today, there's a county-based entity, although the structures are different in Illinois and Texas, that is responsible on some level for being the convener for the process of crisis system design, planning, and implementation, as well as ultimately having some ability, not full ability, to hold accountability for the performance of the entities that are performing the services under contract or through funding and so forth. But the thing that is important to think about here is start by thinking about the importance of bringing your partners to the table for the purpose, who is going to do the convening that is holding this as an accountable process for the whole population. Can we start by bringing partners to the table and building a level of trust, a common vision, and a set of common values? That's all about how this is a win-win-win-win-win partnership for people served, for first responders, criminal justice partners, mental health service partners, substance use partners. Everybody's on board to work collaboratively to take care of the community. And if everybody does their part and builds a level of trust, the whole thing works better than setting up something in isolation that then starts fighting with folks about who they do or do not take and what they do or do not do. So think, who is going to hold the accountability, at least through the planning and implementation process? And how do you bring partners to the table and take the time to build that shared vision and collective vision? The next thing that I want to talk about is to go through some of the details in these pictures, but I want to do that on the next slide. Okay. So one of the things as you're moving forward is the idea that you want to have someone who actually becomes your crisis system coordinator as you go. Who's responsible, not just for a crisis service, because it's very hard for somebody who's running a component of the service to hold responsibility for getting all the partners to work together. How does the crisis center work with the call center, work with the mobile team, work with the intensive outpatient follow-up, work with the urgent care referrals and the transportation entities, and then the connection to the ongoing community care? Who's going to hold that together? What individual or team to make sure everybody works together and continues to, have shared responsibility, shared accountability, and collaboration to make sure that things work and are continually improving their processes. One of the things that may guide you in this process in your community, which is one of the things we learned about as we were developing this, was that in most communities, there's already a similar structure in place for accountability and coordination and quality for the emergency medical system, the EMS system, that involves multiple funders, hospitals, emergency rooms, emergency transport, first responders, that gets together. They have a medical director and an administrative director usually, and they're busy constantly doing this kind of thing to make sure that everybody performs. So in the end, everybody gets the right response in the right place every time. That's a standard quality indicator for EMS. And daring to say that that's what we're shooting for in behavioral health is already a big deal. So the next bullet says, how do we start to think about what we're doing? So it says geographic access is commensurate with that for EMS. And I also want to talk about population access as part of your planning. Okay, so one of the things that we're moving from right now is giving ourselves a round of applause for setting up any crisis program at all, to beginning to think about how do we meet the needs of our total population, both in terms of volume of people and in terms of the geography of people. And I'll give you some examples of how to think about this. There's some data from Crisis Now. There's a thing called the Crisis Now calculator, which you can track down, that has some very rough estimates of the anticipated volume of people who will need behavioral health crisis response more than a phone call in any population. And that is about 200 crisis encounters per month per 100,000 adult people. total population. So it's 2,400 per 100,000 per year. Okay. And so if you're a million, that's 24,000. Okay. For 500,000, that's 12,000. And that's just adults. And for children, it's, somewhere around 15%, maybe 25%, because children may appear in crisis in other places besides the conventional behavioral health places where people are emergency rooms. So you add that in. So if you're planning a service, if you're 100,000 folks and if you have a population of 100,000 in your service area, and your crisis capacity is great, but it serves 200 people a year, you're not where you need to be. Similarly, we have to think about geographic access. So are people able to get to the service close enough? And one of the ways of looking at that is, how do we create access to medical, urgent care, emergent care, law enforcement, and are our behavioral health crisis service distribution near to where people are, both in urban areas as well as in rural areas? So in a large county, that may have 1.5 million people in a large geography, placing one crisis center in a downtown location may not be adequate in either size or reach. And that county may need to be planning, well, we have 4 major quadrants, each of which has a population of, say, 250,000 people, and we want our crisis center and an array of crisis services to be designed to meet the needs of each quadrant. And that's part of our planning. We're not going to get there overnight, but we're going to begin to create that vision. In larger systems, we have more capacity and volume to set up freestanding services. In more rural systems, we may be piggybacking services into existing locations and using more telehealth support from hub services that may exist in a larger or nearby or neighboring region where there's a little bit of population concentration. Just as those same setups support, a level 1 trauma center in an urban area may be supporting rural medical emergency rooms, and there's a way in which they deal with crises like car accidents. And we think about the same structures in behavioral health as well, so that there's a different design for rural areas or frontier areas compared to urban or suburban. But the concept of thinking about the best model for geographic and population access is similar. And thinking those things through and starting to map out where you want to go is helpful, so that when you begin to implement, you're moving yourself in the right strategic direction, rather than thinking that one size is going to fit all or one service is going to fit all. The next thing I want to talk about is payment. Okay, so one of the things that's really important is remembering we're wanting to develop one behavioral health crisis system for the whole population, just like we have one emergency system or one fire system for the whole population. You're having a fire and you call the fire company. They don't start by saying, tell us your fire insurance, and then we'll decide which kind of fire truck to send. Everybody gets the same thing. Okay, so one of the things that most communities do is they start with a funding pot that they have, but and after a while they realize, and this is something where I am in Arizona has developed a well-developed crisis system, one of the best in the country, through their state managed Medicaid arrangement, which has in their indigent care funds placed into their managed Medicaid MCOs that operate regionally and coordinate this whole entity individually and across multiple MCO partners for the Medicaid and indigent population. And they've taken about 10, 15 years to develop this and refine it. It's really quite cool. But one thing they realized after a while is that the same system was providing services to people with private insurance, but it was doing it for free. So the public system was subsidizing private insurance, which was not paying for the crisis continuum. And this is actually surprisingly common everywhere. So think about how to start bringing all the payers to the table, because your crisis system can ultimately be helpful to everybody. And if more payers are involved, the contribution that's required from each to support the continuum is going to be less, just like for other kinds of medical care. So we're developing a system with universal eligibility, all financing, whether you're indigent or commercially insured, you have access to a continuum of services. That's the plan, that's the vision. And you start by bringing everybody in and not saying, hey, you have to pay for the whole thing. But what can you do to be a helpful partner? And if all you can do right now is sit and listen, that's great. We'll learn how to produce value for you, but please be at the table, because the people we serve may be covered by you, whether the you is the city, the county, Medicaid, the Medicaid MCO, a commercial payer, a business that is prominent in the community that may have a traction with insurers, large hospital systems whose ERs are affected by what we do or don't do. There's lots of potential contributors, and successful planning entities take the time to engage those folks, as well as local funding partners like foundations, to bring everybody to the table and start thinking together about contribution and design over time. Next slide, please. Okay, so now I want to move along to, so I want to cover one more thing as we're looking at this, which is thinking about, as you're looking at this comprehensive continuum, you start with what have we already got in our community? And then how do we build on our existing strengths and capacities? And one of the goals of this webinar is to encourage everyone to build, look at what is everybody doing and how everybody can take steps forward to enhance. And one of the opportunities that we're all aware of right now that helps in this design is the dissemination, the expansion of the concept of the Certified Community Behavioral Health Center. And there's some slides later on. And the Austin Travis Integral Care is a good example of a CCBHC that uses its CCBHC status in a helpful way and connects to the Texas funding mechanism for CCBHCs in a helpful way. But it's not the be all and end all, it's just a helpful thing to think about. So CCBHCs all are going to be moving towards some crisis response and level of open access for follow-up. But they're very different organizations in your community. The funding mechanisms may have a prospective payment model, which is great when they do, but most states don't. Most CCBHCs are operating on a grant. The grant includes some element of services. And you want to bring your CCBHC partner to the table along with everybody else and say, what's the best way for you to partner in this? Okay, and how does that contribute to what we all do? And let's use your capacities along with everybody else to enhance your service design. But again, there's no one size fits all for CCBHCs, and for different states are different, but build on the capacity you have and recognize where there's potential value in looking at which services are you going to do, which services belong better over here. Let's figure out together the things we may need to partner up to create, like in a community in Michigan where a hospital and the community mental health center got together to decide to co-develop a crisis center in a county system with a high level accountability across the major health systems and the county executive. So each of these has a different framework for moving forward. So now let's go forward to slide 26. Okay, so now we're going to talk a little bit about within the roadmap. There's some tools that we put in to help you kind of think about implementing, and I'm going to just go over those very briefly and then hand off to my colleagues from Austin Travis Integral Care. Next slide. So these are tools in the roadmap. 10 steps for communities, okay? This isn't designed to like, oh my God, this is complicated. What can we do? Let's make it simple. And then 10 steps for system leaders and advocates. We have local examples. And then we have a report card. It's like it's like 50 items, and you can get together as a community and have a conversation that says, where are we along each of these elements? And we can use that to map our progress. You have to think about this as not something that happens overnight. You're thinking that you're on a 10-year, 15-year road, and you're creating a vision and taking steps forward slowly in this partnership and growing your capacity over time to meet the vision. Next slide. So the 10 steps for communities are things that I've talked about. Identify and convene your community partners, read and process relevant sections of the report, develop and disseminate your local vision according to what we were talking about, identify who's going to be the accountable entity for coordination and planning. Is it a single entity? Is it a collaborative structure that you create? Next. And then within that, who's the planning and implementation team that has stakeholder representatives from service partners, funding partners, people with lived experience, et cetera. Let's do a baseline self-assessment using the report card. Where are we? Where do we want to go? And where are we now? Let's find some early wins. Keep collecting data, collecting financing, bring more partners to the table, and use that to start developing a pro forma for what's our plan and our priorities over the next year or two, with the idea that we're going to keep our planning process in place and continually revisit it so that we take advantage of opportunities and additional resources as they come, and we keep adding more partners and contributors as we start to build our way forward. So with that, I'm going to move forward to the, just advance the slide. We're just going to advance the slide. I'm not going to go through this piece or this piece. Next slide. And here are the slides I talked about for CCBHCs. And next slide. All CCBHCs offer crisis response, as you're seeing, and those are some of the required activities, but they vary in the degree to which they're actually doing those. Next. Next. And here is Austin Travis Integral Care. And Sherry and Marissa, take it away.
Thank you, Ken. Good afternoon, everyone. I'm Sherry Blythe. I'm the Director for Integral Care's Crisis Services, Specialty Substance Use and Justice Initiatives. Wanted to give you a little bit of background on Integral Care, and then I will turn it over to Marissa because this is really an implementation discussion, and I think you'll really see the links with what Ken's been talking about. So Integral Care is a local mental health authority. We are located in Austin, Texas. We serve Travis County, which is essentially has become the metropolitan area of Austin. So as many people know, it's a very rapidly growing area. We are home to the state capitol, the state government, the University of Texas, which has about 50,000 students, and also Dell Medical School. So we have become a very big tech center also nationally. So a pretty diverse community and a very rapidly growing community. Integral Care, as the local mental health authority, Texas has a system of designated community centers that serve geographic areas. Our area is Travis County. We also serve individuals with intellectual and developmental disabilities, adults, children. As a local mental health authority, we have a role that's a convener, as Ken talked about, a convener of partners. We are a planning entity. And then also we have a very large provider continuum, meaning we are a service provider. We generally serve the uninsured or underinsured population. As I'm sure people are aware, Texas is not a Medicaid expansion state. So we are generally serving uninsured or underinsured people. However, we also serve, and I think Ken made a really good point, the crisis system tends to serve the whole gamut, and it's also serving insured people. As a certified community behavioral health center, we do have a crisis continuum. We have a hotline that's a 24/7 hotline. We provide the 988 service for our area. We have a walk-in urgent care clinic. We have residential programs that are part of our crisis continuum to see if we can help stabilize people in the community rather than going in the hospital. And then we also have we have 2 mobile crisis teams. And I'm going to ask Marissa to talk more specifically about these teams or the one team and our work with the 911 call center. This work really illustrates the collaboration across the community, building buy-in amongst our community and working across, as you can see, this particular collaboration is with the Austin Police Department, Austin Travis County EMS, also the Sheriff's Department, although the numbers that we serve through them are a little bit smaller. So Marissa, I will turn it over to you. Marissa oversees this area of our services.
Thank you, Sherry, and thank you, Ken, for bringing us in to give information about our project here in Austin, Texas. I am the administrator over crisis services, so I oversee the mobile crisis outreach teams as well as integration into 911 and our psychiatric urgent walk-in clinic. I want to start off by giving a little bit of a history of our mobile crisis outreach teams, and then where we're at today and steps for the future of our planning. So our original MCOT team started in 2006, and they receive all of their referrals from our 24/7 crisis hotline number. That is also run by Integral Care, and anybody in the community can utilize that number. And if they're experiencing a crisis or they have a family member or loved one who's experiencing a crisis, and an MCOT team will go out into the community wherever that crisis is occurring and respond to provide least restrictive options that are person-centered, trauma-informed, and ensuring that we connect to ongoing services through the 90-day package. In 2013, we were able to expand our MCOT team and develop a secondary MCOT for the purposes of really ensuring that we were looking at gaps in our system. What we identified through looking at data within our own system, as well as our community partners, specifically our police systems and EMS, was that far more people were accessing crisis services through our 911 system, as opposed to calling our community hotline of 472-HELP. And so through an 1115 Medicaid waiver project, we expanded our services, and that MCOT team has the same mission and vision as our original team. The only difference is that they are deployed out to the community through referrals received from police and EMS, as well as criminal justice systems. So I'll go on to, if you can move on to the next slide, because it'll give you a visual of where we were. So we had the original team that was responding through the hotline, and then through 911, a first responder would go into the community. Through training received by our agency, they were able to recognize signs and symptoms of a mental health crisis, and then could request us immediately on site so that we could start our crisis assessment. In the absence of a medical emergency or public safety issue, we would release the first responder back out into the community so that they're really focused on their area of expertise of being available to ensure public safety or respond to medical emergencies in the community. And our clinicians would stay with the individual to do our crisis assessment and facilitate any type of levels of care if that was needed. Very successful partnership in working with the first responder system, as well as the ongoing trainings that we would do each year. And when the waiver requirements changed in 2019, we were able to utilize the data that we had on diversion from the calls that we received from our first responders to really show how successful this project was and what a benefit it was to individuals that were experiencing crisis in our community. So the city and the county assumed funding for that expansion team. And then the city of Austin provided us with an opportunity to integrate our clinicians into the 911 call center. And that was really helpful in that through that crisis continuum, we were able to intercept calls at the 911 call center when a 911 operator identified that someone was experiencing a mental health crisis. They would be transferred over to our clinicians that were co-located on the floor at the 911 call center in hopes that we could provide emotional support, de-escalation, connect them to the appropriate resources, dispatch a mobile crisis outreach team if there was a need for a face-to-face response, in hopes to divert a law enforcement response if there was no public safety issue that was present during that call. That started December 16th of 2019, where we took our first call at the 911 call center. And we started off with a very narrow focus of calls that were able to be transferred because this was a new endeavor for us. It was the first time our clinicians had ever been in a 911 call center or call setting. And it was also a new endeavor for the 911 operators and the 911 system to have our clinicians co-located. It's been very successful. We've been able to integrate more clinicians. We started off with one clinician on the floor for 40 hours a week, and we now have 24/7 availability. During peak hours, we have anywhere from 2 to 3 of our clinicians that are able to get calls transferred over to our clinicians when a mental health call has been identified and routed over to us. So the first part of this visual shows you where we were at, and then where we are now is in that 911 call center. To the second piece, the highlighted visual, we're very proud of adding in mental health services as a fourth option for our community. So when someone calls 911, the call script is Austin 911, are you calling for police, fire, EMS, or mental health services? And for us, that really was a game changer in our community. It happened about a year after we integrated into the 911 call center. And as soon as that option became available, we had we were able to see that calls were increasingly transferred over to us because people calling in were able to self-identify that it was a mental health crisis. And I think it also provided an ability to reduce stigma that mental health is being seen and a mental health crisis is being seen as a healthcare response, and needing that specialty service is just as important as a police response or an EMS response. So that's where we're at today. If we can go to the next slide, please. Some of the strategies that we utilized prior to starting our integration into the 911 call center is we did several site visits to other communities that had already integrated into 911 call center. So specifically, we went to Dallas, Texas, and Houston, Texas, as well as Eugene, Oregon, to see what their call centers look like, that integration looked like, and what their response in the community looked like as they were diverting police when it was not necessary. We use those site visits to come back and really determine what's going to be the best for Austin. So I think that that's really important because there's a lot of communities across the nation that are implementing programs such as this. And every community looks different. The needs are different, urban versus rural populations and things of that nature. So utilizing what other people were doing and seeing what was going to be the best fit really helped us in implementation of our project here in Austin. I touched on this a little bit, that we were bringing two varying cultures together in one center to really ensure that we were getting the right resource out to the right people. And so one of the ways that we helped ensure that that was happening was the clinicians observed the 911 call takers to get a better understanding of their processes and their procedures. And then their call takers would do observations with us so that they could get a better understanding of the referrals that they were sending over to us and what limitations that we had, as well as what services we could provide. So that really helped with the referral process, getting this up and running, but also really focused on ensuring that we were building mutual trust and respect with our different disciplines, because we can't work in a silo and we do need to work together. We did have that common goal, and that's where we were coming from, to ensure that we were getting the right resource out and still ensuring that people were safe in the community. Building relationships with first responder partners was and has been always crucial to ensuring that this project, as well as when we started receiving calls in 2014 with our first responder partners, has been integral in everything that we do, and our training that we provide to our first responder partners provides us with the ability to give them the training that they need to identify resources, how to call us out, but also an opportunity to really have and build relationships in those ways. I will say that additionally, when we started our integration into the 911 call center, we trained all of the 911 operators and dispatchers on mental health first aid, so that they had the ability to recognize signs and symptoms when someone was calling into 911. Of course, the interlocals and MOUs were crucial in development of ensuring the protocols and procedures between the different entities. And I would say that the integration into the 911 call center has been extremely beneficial. I know that that is not always something that every community can do. And there's often sometimes communities where they're transferring out the 911 call center to a community hotline to actually divert police response. However, we've seen so many benefits in the integration that if it is at all possible, we do recommend that that there is that integration. We have found it so helpful, again, to build the trust and relationships with the 911 operators. But we also have the ability to view the computer aided dispatch system, so the CAD system the first responders utilize, so that we can communicate more efficiently to ensure that we're getting appropriate communication out to not only our clinicians, but if we do have to transfer it back to police or EMS, because we determined during our screening and triage there's a medical or public safety emergency, that is getting quickly communicated and transferred because we are also integrated in their technology system. And then, of course, the data collection has been a huge component to ensure that we continue to keep enhancing the projects and goals that we have related to ensuring best practice community responses in our community. Next slide, please. One of the things that we did about 8 months after starting the integration into the 911 call center was look at the cost savings and cost avoidance, specifically related to our clinicians at the 911 call center, and looking at the first responder systems and what the cost was. So what on average the number of police that are responding out, the time that they're there on mental health calls, the cost associated with transport via ambulance, the cost associated with an inpatient psychiatric admission, as well as an involuntary hospitalization. We looked at all of that, and we were able to determine that when we are dispatched out as a team for first response for MCOT, going out as opposed to police, that is about $65 per call. And any call that we're taking on the 911 call center floor is about $10. Since we started this project, it stayed pretty consistent. Of the calls that are transferred over to our 911 clinicians, about 80% of the calls that we handle, we are able to divert from police response. So it's, to us, that is a huge success. Of the 20% that we are unable to divert, about half of those are due to the individual still requesting police response, even after we've offered an alternative response from a mental health professional. So in those instances, we are transferring back to police so that we can honor their request for a public safety response after providing alternative solutions for them. The other thing that I think is really important to highlight is that during that 8-month time period, the overall cost savings and cost avoidance for the project of the calls we had taken to date was about $9 million. And then for our projected outcome for the year, the cost savings would have been $12 million. So the data really spoke to the financial impact that it had within the community and the different systems. But we also had so many success stories that really highlighted the personal experience of individuals when they call 911. A lot of people said they had no idea that this was an option after they were transferred over to our clinicians, and we're very thankful that they were able to talk with the counselor immediately, as opposed to having emergency services deployed out to their homes. I don't have any other information, but I'm happy to answer any other questions, and we'll go ahead and pass it back.
All right, I am Kent Hosopple from Sangamon County, Illinois, Springfield, Illinois. Sangamon County is located in central Illinois with a population of close to 200,000. Our county jail was built for a capacity of 285, but for years we've averaged a daily population of around 335. In 2015, we established our mental health court, and through the relationships formed in that with law enforcement, with behavioral health, in 2016, we started a group of law enforcement, probation, behavioral health, meeting outside of the mental health court to discuss various things, including services, but also individuals who were in the community who they were encountering, not necessarily involved in the criminal justice system, but who were obviously having some kind of issues. It formed a team that would go out and try to assist those individuals without them becoming involved in the criminal justice system. In 2017, Memorial Behavioral Health began doing ride-alongs with law enforcement. And in 2017, we applied for and received MacArthur Foundation Safety and Justice Grant. We were interested in looking at developing a crisis center. So a group of behavioral health professionals, law enforcement, prosecutors, individuals from the courts did 4 site visits. We went to San Antonio, Texas, Tucson, Arizona, Pima County, South Dakota, and Milwaukee, Wisconsin. We also completed a 2-day sequential intercept model mapping exercise with the Policy Research Institute. It was very helpful. We had a really good turnout. We had 56 individuals from the community participate in that. And based on that, we laid out what we would like to do as a community for a crisis detox center. During this time, we also knew that we had services, psychiatric services in the jail, but we did not have the resources to do routine screening for individuals who were brought into jail. So in 2019, we applied for and received the Justice Mental Health grant. And with that grant, we placed a behavioral health specialist in the jail. That individual would go along with a pretrial officer from probation into booking every morning, have conversations with individuals, and try to identify very early on if there were mental health issues related to that individual. And then the pretrial officer and the behavioral specialist would make a recommendation to the court very quickly. The idea was to reduce the number of days that person was incarcerated, and then to actually do a warm handoff when they were released. It is common practice for that behavioral specialist and or the pretrial officer to go with that individual, link them with services. When they left the jail, they had a connection with someone and a map for the services they would receive. Other efforts that we've done locally, Memorial Behavioral Health also began a living room model in 2019, started an assisted outpatient program, outpatient treatment program, and outpatient fitness restoration. Like Austin, we also did mental health first aid training for all of our 911 operators. And I can tell you from 30 years in the criminal justice field, this movement that we've seen over the last 6 to 8 years has really been encouraging to me. We've had changes in leadership, but what we haven't done is lost focus of where we want to go with delivering a system of care that addresses the needs of everyone in the community. The next presenter, Diana Kanabe, is one of those who came in kind of in the middle of this, but brought a wealth of knowledge with her, and she was able to pick up the torch immediately and carry it forward. And I will let her talk more about how we use the map to lay out services in Sangamon County.
Thanks, Kent. So, yeah, I came in 6 weeks before COVID. And I think with all that was going on here locally and certainly nationally, it was very apparent that mental health and the crisis that we were seeing around the area and around the nation was coming to great numbers. And so the roadmap that that Dr. Minkoff went through really has been our Bible. It has been what I was able to anchor to help provide our local vision to our health system, and then vision to the communities that we serve, and help to direct our internal and external partners, much like Marissa was talking about, and I think Kent shared, the community partnerships are huge. And what Kent and the teams before had done through the various grants and planning really also helped to lay the groundwork for us to continue building upon the system. And obviously part of the big piece with the roadmap and looking at crisis system differently is to try to avoid individuals from entering into the criminal justice system if at all possible, even from the standpoint of having law enforcement be that first response. And so in Illinois, a year ago, there was a new legislation that was passed. It's called the Community Emergency Services and Support Act, or CESA. And it sets up a statewide steering committee and then regional committees of those EMS directors in each of our regions as well as the community mental health center directors in those areas, certainly other law enforcement, state police, our Department of Human Services, Department of Public Health, and again, the larger 911 system. And it's that intersection then between 911, EMS, and 988. And our mobile crisis response in our teams that our state is now starting to support financially. And so here in our local area, we set up our first mobile crisis response team of mental health clinicians. In April, they went live in the Sangamon County area, plus one other county that's adjacent to small rural county. And we have seen a tremendous amount of referrals, and we're doing mostly 24/7 with that group. We're expanding to 2 other service areas, so 4 more counties. Initially, those are smaller counties, and we're not going to be able to do 24/7 at this point with trying to get all the staff on board to do that. So we're doing a combination of remote response as well as in-person response and looking at what's happening to make those decisions. We did publish our lines. We have a phone number that comes in for all of the mobile crisis response teams that now our 988 line staff also has access to. And this will be part of the planning around 911, much like what Austin Travis set up. We'll be setting up something so that when someone calls 911, if they have a mental health emergency, they'll be transferred to our line or to the 988 line. So some of those things are the things that are in works with the statewide and the regional planning groups. And until those things are decided upon at the state level, we won't go live with some of those things. So in the meantime, law enforcement and community members can call our mobile crisis team directly for us to respond. Much like Austin and Travis, we've set up kind of protocols for leveling system for when law enforcement or EMS may actually need to respond. So is it a medical emergency? Is it a safety issue? Does it look like there's a public safety or a safety issue for the individuals that are in the home or in the community spot where the person needs a response? Do we need law enforcement to go out and secure the system initially, followed by our mobile crisis response teams? Or is the mobile crisis response team going to go out on site, make the determination as to whether they might need 911 law enforcement response on the site? When we've had law enforcement that are going out and then asking us to come in after the fact, in most cases, law enforcement has determined that it is a mental health crisis. They release the situation to our teams, and that seems to be working really well. And so we'll continue to learn from those pieces. And then the Sangamon County, Springfield is the largest city. It is the state capital, much like Austin is. So, and we have several universities and teaching universities, a psychiatric residency program here. And so working through all of those pieces and partners as a part of this is certainly beneficial. And the Springfield police went after one of the Connect and Protect grants, and that planning has been taking place. Implementation will start in October, and that allows 2 mental health professionals to be right along when law enforcement is going out. And so we will also be setting up and continuing with the protocols for when the co-response teams will go out as versus just our mobile crisis response, which is just mental health clinicians and persons with lived experience. So we are continuing to build out those teams. The next step is we are in planning for an urgent care center, a behavioral health urgent care center, which will include a receiving center for police and 24-hour for sobering beds, as well as up to 23-hour psychiatric observation, and then into a 3 to 5 day psychiatric longer-term crisis stabilization center. So those are the next phases. And then we're also beginning to do planning around children and adolescents and how their crisis system will be structured to deal with that population specifically. So I'm going to turn it back over to the group that I think is going to look at questions and answers. Thank you.
Thank you, Diana. And thank you to all our speakers today for joining. It was a really excellent presentation, a lot of great information. And again, we will have these slides available within the next week or so. And so a lot of the resources that have been discussed will be available on the slides. So now I do want to go over to our question and answers, and we do have some in the Q&A box. So I'm going to start with the first one. So how does Austin anticipate, well, I'm sorry, maybe that one was answered. Sorry. So let me go on to another one. So in Austin, Texas, there seems to be a gap in crisis and the issue of where do you take a person? So somewhere to go. And so can you talk, or are you looking at collecting any data on decisions that were made because of capacity issues? So the person or the emergency system did not have a place to take that person in crisis. Are you looking at that at all? That's for the Austin group.
So I'll take the first part of it. Sonia, hi. Sonia, we know Sonia. So Sonia, these are great questions because you're right. There is an issue with a place to go, and it is connected to, very much interconnected with issues related to people experiencing homelessness in Austin and experiencing serious mental illness. So we are not currently gathering the data related to the question you're asking, Sonia. And I'm not sure how we would go about that. But it is a very good question. We are actually very interested in the Tucson model that Ken talked about because they have an outstanding crisis system, and we've been in conversation and are hoping to go visit because we think that may answer some of what you're asking. Marissa, I'll turn over the question related to individuals with IDD and mental illness.
So individuals that have IDD or co-occurring IDD mental health diagnosis, the mobile crisis outreach teams do receive those referrals and respond. We do serve them through our psychiatric urgent walk-in clinic, as well as our integral care facilities with our crisis residential and respite facilities. Our crisis teams also receive training from the IDD department so that we have the skills and training that we need in crisis response with the IDD population so that we're best equipped to provide that, as well as safety planning. We also have our IDD division that will go into our crisis residential and respite facilities to help support them while they are admitted to our facilities. And so we do have good training and response related to individuals that are we'll do have an IDD diagnosis. If they're suspected IDD or if they're not connected, the MCOT teams, as well as our urgent care clinic, will reach out and help the family or individual connect to services to receive ongoing care.
Great, thank you, Marissa. And here's another question for you, Marissa. Were the savings you mentioned saved by the providers, law enforcement, families, or all of the above? So just more about how or who is benefiting from the savings.
Yeah, I think the cost savings really affects all of the different entities. So I would say all of the above. Looking at the cost savings related to the specific person, how much it costs to just be transported to a facility for an assessment at an emergency department, the cost of transport via ambulance, how much it costs to go inpatient. So personally, the individual in crisis, that cost savings, but the system at large, those are very costly services. As I mentioned, it ties up first responder systems that aren't necessarily expert at responding to the mental health crisis. And so utilizing the services that we have really frees them up and cost savings for their own departments to really focus on their areas of expertise.
I think the only thing I'd add is it means the families also didn't receive a bill for these services that they would have gotten in the emergency department or for EMS transport.
Great, thank you. For dispatcher training in mental health first aid, was it the 8-hour course that dispatchers participated in, or was it another time frame or a different structure?
Yes, it was the 8-hour course. I was present for all of those so that I could answer questions related to the integration. So they got the classroom training as well as specific, how would this look with this new program that we're integrating. In addition, something that we did is we had a working lunch. So it was actually 9 hours where NAMI of Central Texas came in and did a presentation where they had people talk about their lived experience. And that and all of the feedback that we received for the classes was very meaningful and impactful for the 911 operators to hear. And we found people that had specifically called 911 and utilized and had response either from EMS or police, and then going to higher levels of care and what that looked like for them, but instilling hope for alternative responses.
Great, thank you. So here's a question about CCBHCs. So I'll sort of open it up to all the panelists. So what if we don't have a CCBHC in our region? Is it worth looking into establishing a CCBHC, or better to look to other partners who are already providing services?
So let me take that one, Ethan. So, you know, the obvious answer is both and. Establishing a CCBHC is not a short-term goal. And, you know, I don't know, because I don't know where you are and what's already available, what the options are. In most states and most communities who would ask this question, establishing a CCBHC means applying for one of the CCBHC SAMHSA grants that provides a funding stream to help the applicant organization, which is usually a community mental health center, but not always, to add some programs and have a few, not many, extra resources for meeting CCBHC requirements, which include some crisis response capacity, but also include lots of other things. So over time, you know, in a state, the more CCBHCs are established, the more impetus there may be for the state to develop a prospective payment mechanism, which makes the funding support for the CCBHC even more valuable. But most of the 500 some on CCBHCs currently in the country are supported by grants and grant extensions. So that's a good thing to pursue if you have an interested grant applicant, but it's not going to solve your crisis system problem. So the thing that I would recommend is that you start with your existing partners and say, what are we already doing? Where do we want to go? And let's figure out how to bring some collaborative energy to the table, define our vision, as Diana and Sherry and Marissa were already talking about, and find our next steps of progress. And I'm sure you already have some services that are being provided that may be disconnected, maybe under leveraged or under supported. And, you know, when you get together and you start looking around and looking at other communities, including in your own state, you're going to get some ideas about good starting places to help you to make progress toward that vision. And don't expect to get everywhere at once. Just bringing your partners to the table and taking a deep breath and saying, we're going to get where we're going over a period of 10, 15 years, and we're going to make some steps in the next year or so. Yay, us. That collect some data, show how that's producing value, attract more resources, and keep on going.
Excellent, thank you. So just another minute, if anyone else has any other questions.
There was another question that disappeared.
I believe that was answered through the question, the Q&A box.
Oh, good. Okay.
I think
Somebody has her hand raised.
Hi, thank you so much. There's just too much to type. So first of all, thank you so much. This is just so good. My name is Jackie Rodriguez. I'm in Miami, Florida. That's Miami-Dade County. I am in long-term recovery, a little over 14 years. And I thank God finally recently I'm working in full-time recovery substance abuse disorder. I'm an admissions coordinator for Hope Center Ministries. We're a national organization. Long-term meaning 1 year residential. What I want to know is, where can I go locally here in Miami? Like, how would I find out where? I know I know our Broward County is very involved with the 988. I'm actually part of a monthly Zoom that Broward County holds. It's a task force similar to this, but it doesn't really, it's not just about 988, it's other things, but where can I go? Like, how do I find out about this in Miami? Like, I want to be able to go, hey, you know, I got people who want to train in this, who have mental health experience and have qualifications. You know, I want to know how I plug into my local people here that we can get the ball rolling, because it's Miami and God knows.
Well, Jacqueline, you have come to the right place. So I mentioned the roadmap learning community, of which Austin Travis is a member. Another member of that learning community is Miami-Dade, represented primarily by the managing entity, you know, but also by a number of other involved partners. So if you get in touch with me offline, I can give you some contact information, and then hook you up with folks who can help get you connected to whatever is going on that may best fit you. One of the folks you can certainly contact is Laura Naredo from the managing entity, if you're familiar with that organization, but I can just reach out to me. I don't know, Ethan, was my email on there anywhere?
Yes, we have included everybody's contact information, and we can certainly get that to Jacqueline.
Okay, and then one other thing, so that's locally. Now national, because we're a national as well. So we have over 37 residential homes throughout US, and we're growing, like, it's amazing. But so who would be a national contact? I guess I can find that out from you too, Kenneth?
Probably. I mean, I would need to know kind of what level you're interested in gathering that information, but I can certainly figure it out with you offline.
Okay, we'll definitely communicate offline. Thanks again, everybody.
Okay, and then to AD Paul, is there a community you know of that got percentage of operating budgets from governments? Yeah, there are many, I'm sure that, and many I don't know of. I'm going to give you two examples of operating funding partnerships where there was a considerable amount of local contribution, not necessarily from every one of those things, but from a lot of those things. We did a consulting project in Kent County, Michigan, which is Grand Rapids and the surrounding area, a couple of years ago. The county executive convened a partnership of the major health systems. There are 4 large health systems serving that community, and then 2 private hospital systems. And then that became an executive group that convened a larger partnership of community organizations and other service providers to evaluate and then plan funding for their crisis system. So funding contribution for that came from the county government. A member of their governing board was a businessman who was a notorious fundraiser to bring in private foundation dollars and business contributions. Each of the private hospital systems donated money. The local Medicaid intermediary system it's called PIHP in Michigan and CMH in Michigan, they contributed funding, including some money from their CCBHC grant, but also other funding. They also, when we stopped our project, they were in the process of bringing in their Medicaid MCOs, most of whom also had commercial business lines, to figure out how they were going to contribute to the process. There was there were separate stuff around. They have a school a children and youth collaboration with other foundations and school contributions and grant funding and whatever that were funding some of the services that in partnership with juvenile justice. So yes, all of the above. Another example, we just finished a statewide project in Ohio, helping them to design and operationalize their statewide approach to crisis services. And there are several communities that do a variety of things, but one of the ones that stands out is Franklin County, which is Columbus. And Franklin County also brought together contributing partners from their health systems, local businesses, local foundations. They're what they call in Ohio the Adams boards, the alcohol, drug abuse, and mental health services boards that are their version of a county level intermediary system. They had some state dollars and then, MCO partners also sitting at the table with law enforcement and whatnot, so that everybody can contribute to a planning process for both a crisis center with observation, as Sherry was talking about, but also other components in the service system as well.
Okay, thank you very much, Dr. Mukoff. So we are at time. It is 3:30. So I just want to again say thank you to all of our speakers today and panelists, and certainly to all of the participants. Thank you for your questions. This was an excellent discussion. And so from the CSG Justice Center, thank you all and have a wonderful day.
Thank you.